Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in epilepsy for
your left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
You know, usually when we talk about plumbing, it implies this sort of boring maintenance.
Right. You fix a leak, you unclog a pipe, you move on.
Exactly. You just move on. But looking at the research for today's deep dive into the pediatric genitourinary system, the GU tract, I realized that metaphor is actually kind of dangerous.
Oh, it really is.
Because in pediatrics, the plumbing is where some of the most deceptive exam questions and honestly the most deceptive clinical presentations hide. I mean, you miss one subtle symptom, like the specific shade of a child's urine.
Yeah, and you aren't just failing a test, you might be treating the completely wrong disease.
Right.
It's true. The GU system is just notorious for that. It feels straightforward until you realize that a child's kidney isn't just a miniature version of an adult's kidney.
Not at all.
Their filtration rate is slower, their buffers are different, and the developmental stakes are just massive. We aren't just preserving an organ here, we are preserving their future fertility, their physical growth, and honestly, their psychological well-being.
Yeah, which is so crucial. And that is exactly our mission today. For those of you joining us, we are taking this massive stack of materials we have, Chapter 21, the medication protocols, the nursing care plans, and we're going to distill it all down to the Pareto 80-20.
The 20% of the concepts that answer 80% of the questions.
Exactly. And more importantly, the concepts that keep these kids safe at the bedside. And the lens we're using for everything today is growth and development. Because, you know, a toddler needing dialysis is a completely different universe than a teenager needing it.
Absolutely. You just can't treat the kidney without treating the child attached to it.
So let's organize this chaos. Looking at the data we uploaded, the source material really falls into three distinct patterns.
Right, the high-yield patterns.
Yeah. You have the filter failures, which are your glomerular disorders. You have the structural issues, which are surgical. And you have the acute emergencies. I want to start with the filter failures because this seems to be the biggest trap for everyone. The battle between nephrotic syndrome and acute post-streptococcal glomerulonephritis, or APSGN.
Yeah, these two are the heavy hitters. And they are constantly confused because they both involve the kidney's filtration system going haywire, but they do it in completely opposite ways.
Let's break down nephrotic syndrome first. The literature calls this a permeability problem. The way I visualized it while reading was like a colander or a strainer.
Okay, I like that.
Normally the holes are small enough that the pasta, or in this case the protein, stays inside. But in nephrotic syndrome, those holes get stretched out.
That's a perfect visualization. The glomerular basement membrane becomes highly permeable to massive amounts of protein. So the child loses albumin, which is the main protein in our blood, right into the toilet.
It dumps out.
It dumps out. And this is where the physiology gets really interesting. Albumin acts like a sponge. It holds fluid inside our blood vessels. When you lose that sponge, the fluid has literally nothing to hold it in the vasculature.
So it leaks out into the tissue.
Exactly, at third spaces. So clinically, you see a child with massive generalized edema. I mean, they are puffy everywhere.
Wow.
And because that protein is churning out into the urine, if you looked at the toilet bowl, it would look frothy. Think of it like beating egg whites.
Oh, that's a visceral image.
It is. Frothy urine is the absolute hallmark of nephrotic syndrome.
Okay, so nephrotic is the leaky filter, frothy urine, massive swelling. Now contrast that with APSGN. This one seems to have a very specific timeline attached to it.
It does. APSGN is an immune response. It happens typically 10 to 21 days after a group A beta hemolytic strep infection.
Oh, so the kid had strep throat or maybe a skin infection 2 weeks ago. They got completely better, and now they're suddenly sick again.
Yes. And the mechanism here isn't a leaky filter.
It sounded more like a clog in the readings.
Yeah. Think of it like a traffic jam. Your body created all these antibodies to fight the strep. The war is over, but the wreckage of that war, the immune complexes, are still circulating in the blood.
And they end up in the kidney.
Right. They get swept into the kidney's filter, but they are just too big to pass through, so they get stuck in the mesh. This causes massive inflammation and essentially clogs the filter.
So unlike nephrotic syndrome, where the fluid leaks out into the tissue, in APSGN, the fluid is trapped in the blood because the kidney can't pee it out.
Precisely. And that fluid overload in the vascular space drives the blood pressure through the roof. This is the critical safety distinction you have to make.
Okay, tell me.
A nephrotic kid is puffy, but usually has normal blood pressure. An APSGN kid is hypertensive. And because the filter is actively damaged by inflammation, it bleeds. So you don't get frothy urine, you get hematuria.
Which the textbooks describe as
Tea-colored or cola-colored urine.
because it's old, oxidized blood. I really want to nail this distinction because it dictates the entire treatment plan. If I have a nephrotic kid who is leaking protein, the treatment is steroids to stop the inflammation and seal the leak, right?
Yes, high-dose steroids like prednisone. But that brings its own problems. If you put a child on massive doses of steroids, you are actively suppressing their immune system.
Right.
So now, infection prevention becomes the #1 priority. You have to keep them away from sick contacts.
Whereas with the APSGN kid, the problem is they are basically a pressurized water balloon. They have too much fluid and extremely high blood pressure.
So the intervention completely flips. We aren't pushing steroids as much as we are managing volume. We're talking fluid restrictions, sodium restriction, and aggressive antihypertensives. We have to bring that blood pressure down before they seize.
Wait, before they seize?
Yes. Hypertensive encephalopathy is the scary complication of APSGN. If that pressure gets too high, the brain swells. So if you are taking care of a kid with tea-colored urine who suddenly starts complaining of a headache or gets super irritable, you need to move fast.
That is a crucial can't-miss item. And let's look at the developmental impact here, because we promised to view this through that lens.
Yeah.
We're talking about school-age kids mostly for these filter issues.
Right, usually early elementary age.
So imagine being a 7-year-old. You're puffy, your face is swollen, periorbital edema is huge with nephrotic syndrome, and you have to go to school looking like that.
It's devastating for their body image. Erickson's stage here is industry versus inferiority. They just want to be like their peers. If they look different or if the steroids make them gain weight and get that classic moon face, they might just refuse to go to school.
They withdraw completely.
They do. Plus, if they are immunocompromised from the steroids, they can't even have normal play dates. The isolation is very real.
So as clinicians, we aren't just checking urine protein levels. We're checking their mental state. We need to help them maintain social connections safely.
Exactly. We encourage FaceTime, writing letters, maybe safe outdoor activities, anything to keep them part of the group.
Okay, let's shift gears a bit. Those were the slow burn filtration issues. Now I want to talk about the acute emergencies. The moments where the kidneys aren't just struggling, they're actively shutting down right in front of you.
It's scary stuff.
Yeah. The big one in the text is hemolytic uremic syndrome, HUS.
HUS is the most common cause of acute renal failure in young children, usually under 5 years old. And it's terrifying because it starts out so innocently. It almost always follows a simple diarrheal illness.
Usually E. coli, right, like from eating undercooked meat or visiting a petting zoo.
Exactly. The child gets a stomach bug, maybe has some bloody diarrhea, and then they actually start to recover. But those bacterial toxins are still in their system, and those toxins attack the lining of the small blood vessels in the kidney.
And the body tries to heal that.
Right. The body reacts by sending platelets to fix the damage, which creates thousands of tiny microclots inside the kidney's vessels.
And those microclots act like a shredder for red blood cells.
That's the perfect image for it. The red blood cells try to squeeze past these microscopic clots and literally get sheared apart. That leads to the triad of HUS that you absolutely have to memorize for any exam.
Okay, lay it out for us.
1, hemolytic anemia, because the cells are being actively destroyed. 2, thrombocytopenia, or low platelets, because they are all being used up to make those clots. And 3, acute kidney injury, because the clots are blocking the blood flow to the kidneys.
So clinically, this kid looks like a wreck. They're pale as a ghost from the anemia. They might have bruising or petechia all over from the low platelets. And the big tell, they just stop peeing.
Aliguria or total anuria. And they look toxic. This isn't a kid sitting up playing with an iPad. This is a lethargic, pale, really sick child.
And what's the treatment?
It's purely supportive. We can't just fix it with a pill. We have to manage their fluids and electrolytes meticulously. But often the kidneys shut down completely, and these little toddlers end up needing dialysis.
And that brings us to the developmental trauma of all this. Dialysis for a 2-year-old.
It's incredibly hard. Toddlers are all about autonomy versus shame and doubt. They want control over their bodies. Dialysis takes away all control. It involves needles, physical restraint, being tethered to a loud machine. You see a lot of regression here.
Like what kind of regression?
Well, a kid who is fully potty trained will suddenly start wetting themselves again. They lose their words.
And that regression is totally normal. Right. We shouldn't punish it.
Oh, completely normal. It's a basic coping mechanism. As nurses, we have to reassure the parents. We tell them, look, this is temporary. Don't punish them. Focus on survival and comfort right now.
Speaking of survival and comfort, let's talk about the everyday plumbing maintenance. Urinary tract infections and VUR vesicurital reflux. This seems super common, but the presentation varies wildly by age.
It really does. If an adult has a UTI, they just tell you it burns when they pee. But a 6-month-old can't tell you that.
Right.
In infants, the signs are incredibly vague. Unexplained fever, vomiting, poor feeding, or just acting off. Any infant with a fever of unknown origin gets a urine culture, period.
But in the older kid, like the preschooler, we start to see the classic signs. And there's one symptom here that the source material flagged as a major red flag.
Enuresis.
Yes, bedwetting. If a child has been reliably potty trained for 6 months or a year and suddenly starts wetting the bed, do not assume it's behavioral. That is the body screaming that something is irritating the bladder.
And often that irritation is caused by VUR, right, the backflow.
Exactly. VUR is a structural issue where the valve between the ureter and the bladder doesn't close right. So when the bladder squeezes to pee, some urine shoots backward up towards the kidney. It's like a plumbing backup.
Which carries bacteria right up into the kidney.
Yes, causing pyelonephritis and eventually kidney scarring.
And that kidney scarring is permanent. That's the real why we care here.
Exactly. Scarring leads to hypertension and major renal issues later in life. So we use prophylactic antibiotics to keep the urine sterile while we wait for the child to hopefully just outgrow the reflux. Now, regarding prevention, we always hear wipe front to back, but the source material mentioned constipation as a major culprit for UTIs. I feel like parents, and even some clinicians, completely miss this connection.
They do, all the time. Think about the anatomy for a second. The rectum is right behind the bladder. If the rectum is full of hard stool, it pushes forward and physically squishes the bladder.
So the bladder just can't empty completely.
Right. It prevents emptying. And stagnant urine grows bacteria. So treating a UTI often means you have to treat the constipation first.
That's a huge clinical pearl. To fix the pee, check the poop.
Exactly.
Okay, let's move over to the structural and surgical bucket. We have kids born with plumbing defects, specifically hypospadias and bladder exstrophy. Let's start with hypospadias. This is where the urethral opening is on the underside of the penis. What is the absolute can't-miss rule here?
The number one rule is no circumcision. Not initially, no. If a baby is born with hypospadias, you must stop the circumcision. The surgeon needs that foreskin. It's literally the skin graft material they use to rebuild the urethra later. If you cut it off, you've complicated the repair significantly.
That makes perfect sense. Don't throw away the spare parts.
Exactly.
Now, bladder exstrophy. This one is visually shocking. The bladder is literally outside the abdomen.
It's a severe midline defect. The bladder is exposed, it's red, and it's constantly weeping urine. The immediate nursing priority at birth is covering it with a sterile, non-adherent dressing to keep it moist and prevent infection.
But looking long-term, there is a fascinating and critical safety link here regarding allergies.
Latex, right?
Yes, the latex allergy risk.
It's huge. These children require multiple surgeries and frequent catheterizations starting from day one of life. Because of that massive repeated exposure to latex products early on, they develop a latex allergy at a staggering rate. It's very similar to what we see in spina bifida patients.
So for these kids, we are instituting latex precautions for life. No rubber gloves in the hospital, no latex balloons at birthday parties, checking their pacifiers.
Everything. A balloon popping in their face at a party could trigger full anaphylaxis. It's a serious safety education point we have to drill into the parents.
Okay, now let's talk about the reproductive system. We have to touch on the emergencies where time is tissue, specifically testicular torsion.
This is the heart attack of the groin. The spermatic cord twists, completely cutting off blood supply to the testicle. The pain is sudden, it's severe, and it's often accompanied by vomiting.
And the need to know here is the clock.
You have about 4 to 6 hours to untwist that cord surgically before the testicle dies.
So if a teenage boy comes into the ER hunching over, walking funny, or complaining of severe lower abdominal pain, you need to check the scrotum.
You absolutely have to. Adolescents are modest. They might lie and say their stomach hurts because they're just too embarrassed to say their testicle hurts. You have to physically check. If it's swollen, high-riding, and painful, they go to the operating room immediately. You do not wait for labs.
Contrasting that with cryptorchidism, which is undescended testes, this isn't an emergency today, but it's a massive risk for tomorrow.
Right. If the testes don't descend, the sperm-producing cells get damaged by the core body heat. This leads to infertility. But the much bigger risk is testicular cancer.
Even after surgery?
Yes. Even after we surgically bring them down, a procedure called an orchiopexy, the risk of cancer remains significantly higher. So these boys need to be taught how to do testicular self-exams early on.
Let's weave in the pharmacology now. The source material highlighted a few specific meds, and I really want to focus on oxybutynin, ditropin. I usually think of this for overactive bladder in adults, but why are we giving it to kids post-op?
It's a powerful antispasmodic. After we do surgery on the bladder, like for the Hypospadias repair or the extrophy we talked about, the bladder gets angry. It spasms, and bladder spasms are excruciating.
Like cramping?
Yes, sharp, severe cramping pain that regular opioids often don't even touch. Oxybutynin relaxes that smooth muscle.
But it's an anticholinergic, and we all know the rhyme. Can't see, can't pee, can't spit.
Can't poop. That's the danger. Severe constipation.
So wait, we give them this to stop the spasm, but then they get constipated.
Right, and think about the physics of that. If you have a child who just had major bladder reconstruction and they get constipated from the oxybutynin, they are going to strain on the toilet. That Valsalva maneuver increases intra-abdominal pressure.
Oh, no.
Yes, that pressure pushes right against the fresh sutures in the bladder. You could literally blow the repair wide open.
Wow. So managing the side effect isn't just about the kid's comfort, it's about physically protecting the surgery.
Precisely. Stool softeners, aggressive hydration, and monitoring bowel movements are absolutely non-negotiable when you are using oxybutynin in these post-op kids.
That is such a great connection.
Mm-hmm.
The other meds mentioned in the module were topical steroids and antibiotics.
Quick hits on those. Topical steroids are used for phimosis, which is a tight foreskin. It thins the skin over time to help it stretch, so you hopefully don't have to do surgery. And antibiotics, as we mentioned earlier, are crucial for VUR prophylaxis to prevent that permanent renal scarring.
Man, we have covered a ton of ground today. We've gone from the traffic jam of APSGN to the shredder of HUS to the plumbing backups of VUR. But before we close, I want to circle back to something you touched on earlier, the bedwetting and uresis.
Yeah.
You called it a provocative thought in our pre-show notes. Why?
Because it's the perfect example of why pediatrics requires a detective's mind. Think about it. If a 7-year-old comes into the clinic with enuresis, it is so easy to dismiss it. Parents are annoyed, they just want it fixed, maybe they think the kid is being lazy.
Right, they just want a quick solution.
Exactly. But as a clinician, you have to pause. You have to ask yourself, what is the body really saying? Is it a structural issue, like VUR?
Is it a hidden UTI from constipation?
Yes. Or is it the polyuria of new-onset type 1 diabetes? That's a very classic presentation. A kid who is suddenly drinking a lot of water and wetting the bed at night.
Oh, wow. I wouldn't have instantly jumped to diabetes.
You have to. Or, and this is the really uncomfortable one, is it sexual abuse? Regression and sudden bedwetting can be a major sign of trauma.
It's just a symptom, not a diagnosis.
Exactly. Never take wetting the bed at face value. You have to peel back the onion. You might find a simple infection, or you might save a child from DKA, or you might pull them out of an unsafe home situation. You always have to stay curious.
That is an incredibly powerful reminder. It's not just about the plumbing, it's about the whole child. Well, expert, thank you so much for breaking this all down. To our listeners, take these 80-20 patterns, the filter failures, the emergencies, the structural fixes, and use them to organize your studying and your bedside care.
And remember, protect the kidneys, protect their growth, and always listen to the parents.
We'll see you in the next deep dive.